a lot of things are now put down to menopause or perimenopause symptoms when it could potentially be something quite different.
Yeah, I think that's a point that we could probably broaden to a lot of women's health, if I'm really honest. You're absolutely right to say there's a big focus on menopause. And I think that it was an important and is an important focus because so many women are going to be going through perimenopause for many, many years. And it does really have a massive impact on people's life, energy, function, mood, etc. I think what I see a lot of is, particularly in things like pain, is that it's automatically assumed, which is the point that you're making, that it is pelvic pain due to endometriosis. And what we find is that the basics haven't been done, so have you tested somebody's urine? Have they got a kidney stone? Is there something else going on with the bowels or the back or the joints? Because there are multiple organs in the same area. Whilst there is great amount of awareness on things like menopause and endometriosis, we do need to make sure that we, like you said rightly, don't miss other stuff.
Welcome to the 51%, the podcast where we cut through the noise and get back to basics when it comes to women's health. Through expert insights and powerful personal stories, we help you tune in to what really matters. Your body, your well-being, your life. No one-size-fits-all advice, just real conversations to help you understand your health on your own terms. But before we dive in, I have a quick favour to ask. Please hit subscribe and join the 51% community on our website. It's free and it helps us grow, reach more women and create events that really speak to the health and wealth challenges we all face. And finally, just so you know, everything shared on this podcast is for information only. It's not medical or financial advice, and always speak to a qualified expert for support.
Aamena, welcome to the podcast. It is great to have you on. I am really excited about this conversation because it will be delving into the system, the NHS system, the healthcare system, which is something I think we all need to hear. The aim is to hopefully get people advocating for themselves as well. So could you please introduce yourself and talk a little bit about your background and what you are doing now? That would be great. Thank you so much.
Well, thank you for inviting me. It's a real pleasure. I'm excited to be here as well. My name's Dr Aamena Salar. I'm a GP in Birmingham, 25 years in the NHS, just about. Most of which has been in women's health. So over half of that has been in women's health. Some of the main things that I've done is created a community gynecology service in Birmingham that's been going for about 10 years. And we see about 15,000 women per year. So I bring a bit of experience on the ground of delivering both general practice and women's health.
That's great. Thank you so much. So you talked about the community gynecology side of things. What does that mean exactly?
Well, I don't know where to start. I think my career took a bit of a turn for the better, where I had a golden opportunity, which I seized. I was very, very fortunate where I was given a blank sheet and I was asked to redesign women's health services for our population. And that was in 2015. Luckily, I was also given resource. I was given a managing director, Sapna Shannon, who's got a huge amount of healthcare service mobilisation. So she'd done a lot of this. And Susanna, who was the finance director. And I named them because the three of us sat in a room, mapping it all out, planning it all out, costing it all out before we even went. So it wasn't just me. There was a whole team of people behind us. But I started with a vision, which I didn't really realise was innovative. I just kind of thought, why are women going to hospital? We're waiting for an appointment for them to go to hospital. Often they would go, having waited a while. And remember, this was 10 years ago, and things have got worse in terms of waiting time since then. And then they'd come back and see me anyway. And that was because hospitals were under pressure back then, and even more so now. So often the letters would come back sort of saying, would you please do the needful? So people were kind of confused about what their diagnosis was and then left to figure out the treatments. So I was thinking, why do they need to go? And the second question was, why would you need to see a consultant? A lot of this doesn't require an operation or for you to be in hospital premises. So why can't we do it in a more friendly environment out in the community? So those were the kind of two questions I always kept at the centre of what we designed. And me being me, I just thought, right, you know what, actually we can do all of this. We can pull it all out into the community, and we can upskill primary care, so GPs, nurses, pharmacists. And unless they really needed to, they could then go into a hospital. So the demarcation was if they needed a general anaesthetic, if they needed an operation or something more complicated, expertise that we didn't have, they would be transferred to hospital. And we designed that service alongside consultants, so we were supported by the hospitals and they approved the pathways. I trained alongside them for many years, so they knew who I was and they were confident that I could manage these conditions. And then from there, we got contracts. From the pilot, we got contracts directly from our hospitals and now what's known as our ICBs. And so 10 years on, we've kept on going. And more recently, we've spent a bit of time trying to share experience, knowledge. How did we do it? Try and get other people to do the same thing. And so we've got a lot of support from some of the national leads in women's health, like NHS England and Department of Health, where they're trying to get other people to replicate their version of these type of services. Sorry, that was a long answer. But
well, I think it's important to get the kind of step by step because otherwise you're going from one thing straight into something else. Why gynecology? Because there are so many women's issues and other issues that could be going on with women. Why did you particularly focus on gynecology?
This is where I've got to be really honest, okay? So I'd love to say that it was always gynecology that was a passion. It found me, in actual fact. So my background was in hospital medicine, and I thought I was going to be a cardiologist. And then I had kids, and it was quite a hard, tough balance working those kind of hours, as you can appreciate, weekends and on calls. My husband at the time was also doing a surgical specialty. So I thought, right, okay, I'm going to come out of medicine and I'm going to do general practice. And when I arrived at the practice, and it's in quite a deprived area of Birmingham in Aston, I arrived and I still had this idea that I could do community cardiology. And I'll never forget, the first day I arrived, the practice manager said, could you finish your contraception training? Just get that done because you're a female GP in an area that people want to see women. So I was like, okay, that's fine. I'll do coils and implants. So I started off with contraception and then I became the go-to for women's health. And I found that I needed a lot of upskilling because, contraception's different to gynae. So I had a lot of investment from the partnership, from Modality, in terms of training to make sure I was proficient. But it found me. And then the rest became history. The pilot came and then we carried on going for 10 years now. So, yeah, I don't want to be a cardiologist anymore. I quite find it's very fulfilling with women's health. So it did find me, but I truly still love it. It's a passion. And every day I hope that we make a difference. And, I can see that when people walk through the door. And actually, that's all I wanted to do when I became a doctor, is genuinely, most of us want to make a difference, want to make things better.
Yeah, absolutely. Do you think over the years that you've been in practice, have you seen at any point where things were getting better in terms of waiting lists, or have we always been on this kind of decline where the waiting lists are getting longer and longer? And I'm talking up to the point of COVID, because I appreciate during COVID things went a lot worse.
Yeah, I mean, it's most definitely got worse. When I talk about setting up the service 10 years ago, we were dealing with a 4 to 6 month wait. Actually, I think it's shorter than that. And even then it was a bit problematic because we were like, well, people were still waiting for some length of time. Now, we read out referrals and people are waiting a year, 18 months. We've got currently 750,000 women waiting for a gynecology appointment.
Yeah.
It's one of the worst hit specialties. And I think those numbers have doubled since COVID. So the demand has gone up, but the capacity hasn't been matched. So we're definitely waiting longer.
Was there ever a time where things were getting better, do you think?
Do you know, that's a hard one to answer because I guess I'm skewed because we've always had short wait times in the service. So we've maintained a less than 4 weeks wait time in the last 10 years. So when we designed the service, we designed it with efficiency in mind. So we would have pathways for each condition. We'd know what we're doing. There'd be no duplication of diagnostic tests. Yeah. When people were handed over, again, it was all sort of verified, if you like, and then it was more of a seamless handover. So that's my experience to date. So yes, I've seen it better, but I haven't seen it scaled. It's still a postcode lottery. You will get areas and services that run very efficiently, but that's not available for everybody.
Yeah. So I guess, are you saying that because you have this community set up, it's almost reduced the waiting lists and that's not replicated everywhere? Is that what you're saying?
Yeah, absolutely.
Yeah.
Absolutely. So we've helped our local hospitals, post-pandemic particularly, drive down their waiting times. They were very badly hit, some of the areas in Birmingham. Those were the ones that we were reading referrals out from 18 months back. People have forgotten why they were referred. And sadly, a lot of them were just staying with the same problem. They were sitting with the same problem, waiting for help, for things to be unlocked. So yes, I think services like ours, and there are many examples of it, can help to drive down waiting lists. And it's not just about waiting lists, it's about timely, early access to health.
Yeah.
But the difficulty is the way in which services are commissioned, and there is no national sort of gold standard or framework to scale it. So we're left with each person in each area having different setups. And that's a problem. That's a real big problem.
So what is the block where, what you've created can't be replicated in different towns and cities across the UK? Because it sounds like and I'm not saying, I know you have to look at the demographics and you have to look at lots of things because each town and city is very different to others. But if we were going to replicate something similar to what you've created in Birmingham, why can it not be done in other areas?
I think it's a very complex question, but I'll try and give you my view. The women's health strategy of previous government set out to try and design services across the country. There were, unfortunately, though, 42 versions of that. And so a bit of the problem was that there was no standardisation of what a women's health hub or community service looked like. Everybody did something slightly different. We started reinventing the wheel. The other thing was that there was no future funding. So that funding was for 2 years, tops, and then there's no future funding that's come. And if I look back on when we set up the service, I'd already had years prior to mobilising the service in terms of investment. My career was already going in that direction. It started off with contraception training and then gynae and then hysteroscopy, even before I started to deliver the clinic. So that type of investment in workforce training, in the infrastructure, it's not just clinical, it's managerial, admin, IT, estates. You need all of that in the background, and you need it to be sustained to build on these services. Because what we learned is that when you start, you think you've designed the best thing because everyone's passionate about what they've done, and that you learn then the population requires something different. So example of that was that we thought virtual first appointments would be great, telephone call, get some information from that person. But what we found is people were like, who are you? There's no rapport, no confidence, no trust. Ringing me up out of the blue. And then people needed to be seen because they needed tests, they needed examination. So that didn't really work. So you need to try, test, reiterate, and then roll up, scale. And all of that takes time. And like you just mentioned, there is local variation and populations that require something slightly differently. So anything that we've seen has tended to be short term and not funded long term. And then the sharing hasn't been spread. I suppose that's the kind of nutshell of it.
So today is the 27th of April, and I really want to read something out because it was in the headlines on the BBC. Today, the BBC headline, it says the UK healthy life expectancy falls by 2 years in the past decade. And over the past decade, the healthy life expectancy has dropped by around 2 years to just under 61 for both men and women. I mean, that's actually not surprising, but it's almost a case of, I feel like, where are we going wrong? What are your opinions on that?
Prevention. We really need to invest in prevention. I mean, even services like ours in Birmingham, they're not necessarily prevention. They're reactive still. They're early intervention. We need to invest in people living healthier in order for them to live longer. The other thing is there are what we call wider determinants of health. It's not just health, it's housing, it's education, transportation, all sorts of things that factor into people's life expectancy. So we need funding for all of that, and we need to invest in prevention.
There's lots of disparities depending on where you live as well, right? And I know that on the radio they also mentioned that someone living in an example, Richmond upon Thames is going to have a far better, healthier life and a longer, healthier life than someone living from a deprived area. And it's also, I guess, tackling those issues as well.
Absolutely. So, that highlights the determinants of health that we talked about, but also the fact that people generally from more affluent areas speak English, hold down decent jobs, maybe have additional income to pay out of pocket for health, which people are doing increasingly. They can also advocate for themselves. They can navigate systems. They can defend themselves. And so what you find is that people who don't have any of that struggle. And we see that in many aspects of health. For example, cancer. People of ethnic backgrounds, the Black community, tend to present late for cancer, having maybe presented several times, and unfortunately don't have the same life expectancy or prognosis following that cancer diagnosis. So unless we level that field and we address those issues, we'll continue to face these problems.
Yeah. So it goes quite deep, really. It's not just about let's just throw more money at the healthcare system. There are other underlying issues that also need to be addressed. So there's a lot to consider.
Yeah, absolutely. We need to understand the problem, and we need to be more targeted in our interventions. We need to be more mindful or meaningful. I think meaningful is a better word in terms of what we're trying to do.
So you talked about, obviously, we know the waiting lists have increased a lot. If you're someone faced with a diagnosis or, are put on a waiting list of some sort, how can you advocate for yourself and perhaps be seen a lot sooner? Because the waiting list, people are waiting for a very long time. And I've noticed even during that period they're waiting, things tend to get worse and your condition gets worse, which then means you might need another referral, which then means you might be waiting even longer. And it's almost like a huge knock-on effect.
Yeah, I mean, I think this is a really important question. And I think it's one that, if you don't mind, I'll take some time to answer.
Yeah.
I think there's lots that people can do while they're waiting. And I think there's some practical tips that I'd like to give people. One of the things is track your symptoms, have diaries, symptom trackers, period trackers. There are lots out there. It helps you understand what's going on. And if there are any triggers, it also helps you collate that so that when you do get your appointments, you're able to kind of succinctly hand over the story to your clinician. Because sadly, with the best will in the world, there are a certain amount of time that you have with that clinician, and you want to maximise it and make sure it's efficient. Try and track symptoms, try and track your periods if it's related to your periods, and start to get trends and start to try and understand what's going on. With that, there's lots of information out there. You can go out to YouTube Health or, various other sources. Just be really careful that you are going to verified areas of information. A lot of charities do fantastic information like Endometriosis UK, Verity for polycystic ovaries. And a lot of them are verified by medics. So you know that they're fairly robust in what they're advocating. I think the other thing that I see, which is quite sort of sad and tragic really, is that when people are waiting a year and 18 months, their care just goes on hold. Nothing happens whatsoever. And what I'd really call for people to do is actively try some treatment while they're waiting. In actual fact, it's really helpful on the other end when somebody like me is seeing you to see what has worked and what hasn't worked. And when you're tracking your symptoms, track your response to treatment as well. So, for example, endometriosis, you may use hormonal treatment, non-hormonal treatment, pain relief. Give something a go. I know lots of people have got opinions about hormonal treatments, contraceptives, pills, coils, but we use a lot of that as medical treatment for bleeding disorders, for pain. difficult is when people wait that long and then they get that advice having waited so long.
Yeah.
And they kind of think, well, one, why wasn't I not told to use something sooner? And their expectations are slightly different by the time, obviously, you've waited that long. You're thinking something major is going to happen on that first appointment. And often it's still gathering of information, gathering of tests before we can kind of really definitively treat you. I think that the other point is a lot of these conditions, particularly in women's health, are chronic, and a curative treatment sometimes doesn't exist. More often than not, they don't exist. So managing your symptoms long term is what we're facing, whatever that is, whether that's polycystic ovaries or endometriosis. Even surgery is not a curative treatment. So, you know, the sooner you can start to understand what's going on yourself, gather information, try treatments, I think the better, because you find out what works and what doesn't work for you. And unfortunately, it is trial and error. The other thing is you've got escalation points then. You know, if your GP says, let's try you on a mini pill, for example, for your pelvic pain, which is a reasonable way to go. You try it for 3 to 6 months. You're still waiting. Your pain is getting worse. That's a good point, an appropriate point to go back to your GP and say, this is not working, I'm getting worse. And they can try to expedite the appointment. And then they've got clinical grounds to send some advice and guidance across to the specialist or a repeat referral. The last thing is that people should be aware of their rights. So the right to choose. You have a legal right to choose where you go in terms of clinics. And there is an electronic referral system that your GP will use that often helps tell them what's your closest provider and what the waiting times are. Be aware of that. You can go back to your GP and ask, well, my local hospital's 18 months. Is there anywhere else that I can go? And what you'll find is there are multiple services, some of which your GP may not be aware of because they open their doors and they close their doors. So it's impossible for your GP to know what's on there, what's around them at any one time. But it's reasonable for you to go back and ask. And that electronic referral system is a live data set that should be able to tell you what's going on.
Yeah. I think the key one is the last one that you've just mentioned as well, because I did not know this. And this is something I found out recently. My daughter was on a wait list for something, and I phoned the GP and I said, look, she can't get to the appointment that's given because she's away at university. I need another one. And they said, well, she's on the wait list for something else and so on. And then all of a sudden they referred her to another hospital, and it was a private hospital. And so I got a bit confused and I thought, that's a private hospital. I wasn't sure what was going on. And we went to the appointment and, you know, all in the private setting, saw a private consultant, and so on. So I got a bit confused. So can you elaborate on that? Because I think that's quite important, something people don't understand, and I certainly didn't understand.
Yeah, so hospitals, in response to waiting times and capacity issues, will sometimes contract their work out to others. So we're subcontracted by our hospitals. We are defined in the outpatients clinics as a private provider, but mainly to the NHS. So what you'll find is that in your area, your hospitals may have contracted out to another provider. It might be in a private setting, or it may be in a community setting. Sometimes, you know, it's difficult.
Yeah, that's right, yeah.
But essentially, that contract is with your hospital. So you are seeing your hospital, if that makes sense. So it's just a capacity issue. They're just trying to increase the amount of clinics and availability of appointments. That's where, again, I think your electronic referral system will crop up, and it's via your GPs and their secretaries will be able to tell you whether those services are live and available to you. And they change on a weekly basis. So that's where I say, go back if you're waiting and symptoms are changing, or you just want an update. It's perfectly reasonable for you to sort of say, is there anywhere else I can go, and what's their waiting times like?
Yeah.
And also, if you're willing to travel, it doesn't have to be on your doorstep. We have people that were willing to travel an hour to see us. So that boundary of area doesn't also exist as well.
Oh, really?
Absolutely.
So how does that work in London? I'm not sure if you're aware. So obviously we have all the boroughs. If you're part of a borough, can you go to the right at the other end. You know, if you're in the West London, as an example, in the borough of, I don't know, say Hillingdon, can you then go all the way to a borough in East London?
Potentially.
Oh.
So I think, again, it's worth, each service will have a referral criteria, but the point being is area alone isn't a reason not to see somebody.
Right. Okay, I wasn't aware. I think this information is it can really be a game changer for a lot of people, because I certainly wasn't aware of knowing that I could be referred to other hospitals or clinics just by the GP checking the wait list.
Yeah, absolutely. I think it's navigating the system that can be a minefield. And I think the other thing that is helpful is for people to try and keep a track of their own records. If you are going to another area or another clinic, even if it's a mile down the road, they don't have your records necessarily. So I think that's another thing that causes people a lot of confusion, is the assumption that we're all got shared medical records. And so now with the advent of the NHS app, it's actually quite helpful when you've got your bloods, your scan, things like that. And you are entitled to get letters from each of these appointments so that you can potentially carry them with you. So just bear in mind that if you are going to do that, or if you're going to do it regardless, it's helpful for you to keep tabs on your previous appointments. And I think what we see, not just in women's health, is there's so much fragmentation of care. You know, when people get referred, they may be seen once or twice, then they go somewhere else, and their records don't follow them. And it can be really frustrating for that individual, because it feels like repetition, duplication, and they just don't feel like their care is being carried forward or going forward. So again, if you can, when we talk about advocacy, keeping some kind of record of your health, whether that's on your NHS app or in a file of appointments that you've been to, I think that's really, really helpful. I think the last thing that I forgot to say before, in terms of advocating for yourself, is, again, it's reasonable to bring somebody along. You know, actually, when we're doing procedures, when I do procedures like hysteroscopy, I tell people to bring someone along. It's a painful procedure. With the best will in the world, we know we have things like local anaesthetics available. But to be in a room with unfamiliar faces versus having somebody hold your hand who you know and can drive you home and get you a treat on the way back, it's a much better experience. But same thing is that when you bring somebody in with you, they may ask questions you forgot to ask because you're nervous or you're worried about what's going to happen in that appointment. And it's helpful to have that second pair of ears. So particularly for those that don't speak English, if you can have somebody that can come in with you who can, again, speak on your behalf or help to translate, or to even just be that trusted person, I think it's really, really helpful.
Yeah, absolutely. I think experience recently, my mum can speak English, but I think there's a bit of confusion sometimes, and, you know, articulating exactly what she wants to say and things. And I recently went to some of her appointments, and just me being there and articulating in a different way and requesting certain things in a different way, it was very different, very
Absolutely.
different. Yeah.
You do have to advocate for yourself.
Yeah.
I'm not sad about saying that. You know, you do need to speak up. And if you don't agree, you don't agree. Sometimes you might misjudge, or you may not have really heard, or for whatever reason that clinician hasn't really understood. So you do sometimes need to kind of go, no, actually, this is the case, or this is really impacting on my life, or I'm not happy with this plan. And that's okay. I think people get really worried about doing that, about challenging. And I think there's still a lot of respect for doctors, for the sort of the healthcare team. And I think maybe they shy away from that challenge. So I think it is important to be prepared before you come through the door. That's where the symptom trackers and the sort of monitoring of response to treatment is really helpful. But also knowing what you want, if you can, before you come. Because otherwise you might end up getting flooded with loads of choices, and then you have to go away and think about it. Wouldn't it be great if you had some information beforehand, so you knew surgery's not for me, I want to go down this route, and then you can personalise your appointment to what you need in an ideal world.
Yeah, absolutely. Another thing I think is quite a powerful question to ask when you're with your GP or a consultant is asking why why do I have this, whatever that is, whether it's a headache, whether it's anemia, whatever, because when you ask that why, it's followed up by, okay, maybe we need to investigate why then.
Absolutely. I think the one thing I would say is sometimes we can't answer that.
Yeah.
But you're absolutely right. With the why comes the tests or the investigations.
Exactly.
Rightly so. Sometimes we can't give you the answer, but the very minimum is we should rule out stuff by investigating. And that's where timely access to diagnostics is key. And having those out in the community is something that I'm quite passionate about.
Can we talk a bit about menopause? I feel like there's so much out there now with the menopause, which is great. People are talking about it. There's a lot of media attention on it. There's a lot on social media on it as well. I also feel like, though, a lot of things are now put down to menopause or perimenopause symptoms when it could potentially be something quite different. And now because the symptoms, it could be menopause, but it might not be. It could be something else. Do you think that could cause an issue with everything just being put down to menopause when something serious could also be going on?
Yeah, I think that's a point that we could probably broaden to a lot of women's health, if I'm really honest. You're absolutely right to say there's a big focus on menopause. And I think that it was an important and is an important focus because so many women are going to be going through perimenopause for many, many years. And it does really have a massive impact on people's life, energy, function, mood, etc. I think what I see a lot of is, particularly in things like pain, and so that's why I'd like to just broaden it for a minute and then come back to menopause, is that it's automatically assumed, which is the point that you're making, that it is pelvic pain due to endometriosis. And what we find is that the basics haven't been done, so have you tested somebody's urine? Have they got a kidney stone? Is there something else going on with the bowels or the back or the joints? Because there are multiple organs in the same area. And so I think whilst there is great amount of awareness on things like menopause and endometriosis, we do need to make sure that we, like you said rightly, don't miss other stuff. And also be aware that there's only so much that, you can manage. So, for example, in the menopause treatment, sometimes there are other issues that are going on. For example, we know that depression, PMS, ADHD becomes more prevalent in this sort of time. And they need slightly specific and different treatments. And so medicalising somebody with just hormonal replacement treatment, for example, may not be appropriate. It may work for some, it may not. Yeah. So we need to make sure that we keep that breadth and think about other stuff. And also try and be a bit more holistic in our approach. And as clinicians, we're a bit clunky at that. Some of the feedback that we've had from the service users, so people that have come through the service, is, and we love it, but you have to, you kind of feel like you're falling short and you have to hear it. And what we've heard is, you're great at diagnostics. You're great at telling us that we haven't got cancer, for example. But then I'm left to manage my mood, my weight, the other aspects of health because you don't provide that. And those are the things that probably are more impactful longer term than a prescription for something. I'm not downplaying the fact that HRT's great for some women, but it's not the answer for everyone.
Yeah, I think it is absolutely correct, because I feel like when someone goes to see someone, you're looked at just for that one specific thing. You're not looked at as a whole person. And I feel like, correct me if I'm wrong, I'm not saying all GPs do this or all clinicians do this, but the questions of, we talked about preventative care, which is so important. What are you eating? What's your mood like? How are you feeling? Are you going through mental health issues? I mean, there could be all sorts. If you're not looking at that on top of the symptoms you're experiencing, then you're not treating anything as a whole, and that preventative side is not really working then.
Yeah, you're absolutely right. And they're often intertwined. What you're eating, how you're sleeping affects your mood, various other things. There's an overlay of mental and physical health, I think. So, there isn't a simple quick fix answer, which is, again, I think the point that you were trying to make. Menopause isn't just HRT treatment. It's a whole load of other stuff.
Yeah.
And people are wanting to look after themselves. We know this after COVID. We've become a more health conscious society.
Yeah.
So people are focusing on their diet, rightly so, diet and exercise. They're looking at what they can get over the counter, wearables, tech, online. I mean, there's a huge boom in femtech, for example. And they are wanting solutions that they can do for themselves. And as clinicians, we're not brilliant at bringing that all together because it sits outside of the traditional appointment setting or provision of care. So we need to be, as you rightly said, more holistic, more personalised, more joined up in what we're doing.
With waiting lists, is there an ideal waitlist time in terms of you go and see your doctor and you find out the waitlist is 2 weeks, 3 weeks, 4 weeks, perhaps 6 months? How do you know as a patient whether that's too long or whether that's just about right?
That's an interesting question. I could answer that in different ways. I could answer it in an official way. So the official waiting time, the national standards, people are meant to wait from GP referral to treatment is 18 weeks. And the target
18 weeks.
18 weeks
Wow.
from referral to treatment.
I'm assuming that depends on what the issue is.
That's across the board. Doesn't matter. That's not specialty dependent.
Right.
So that's called your RTT time. And we've got a national target of 90% of people should be seen within 18 weeks. And as I mentioned before, sadly, that's not happening. So I'm guessing that the reason that was set was because that was felt to be an appropriate wait time. Don't ask me what the evidence was and the research was behind that. What we're finding is that over 50% of people are waiting way longer than that. I think the other way of answering it is that waits is individual. It depends on what impact symptoms are having on your life. Somebody might find it appropriate to wait for 6 months because they have got some level of discomfort or some level of bleeding, for example, but they're able to manage it, or they've started some treatment and it's working to some effect and they're waiting for an opinion. It could be in preparation for. So, for example, somebody's got fibroids and they're wanting to get pregnant, but it's not imminently affecting them, but they want to try and get some advice about what to do, versus somebody that's in pain every day, off work, affecting their relationship, and that, to them, they're in crisis and they need to be seen sooner. And unfortunately, the system doesn't flex itself, doesn't really differentiate between those two individuals very, very well at all. And so I think waiting times are, I guess, an arbitrary thing.
Yeah.
We're currently sitting at it's not acceptable to wait a year, 18 months, no matter what scenario that was.
Yeah.
But you know what I mean? Whether you wait 18 weeks or whether you need to be seen at 2 or 3 weeks, it depends on your individual symptoms and how much impact it's having on your life.
Yeah, absolutely. And that's true. But I just wanted to put that question out there because I think some people aren't sure what is the right, an adequate time period to wait. And you're right, absolutely. If it depends on how much pain you're in and how it's affecting your life as well.
Yeah, and sadly we see people go to A&E because they've been referred and maybe they've gone back. They've tried to get their GP to expedite the appointment to mark it as urgent. Maybe that hasn't happened and they present in A&E with terrible anemia requiring a blood transfusion, or sadly cases of stage 4 cancer. And this is what we're seeing, is that in this strained system of people waiting long, they are now presenting acutely, which I think is probably the saddest thing. How are people coming into A&E when we should be able to see them in a timely way in outpatients?
I'm going to ask you it might be a bit of a tricky question, but if you were in charge of redesigning the whole thing, had a blank canvas and could start again, or maybe not, or improve, just completely transform the way things are done right now. So the wait times are reduced, people are getting amazing healthcare, no matter where you're from, whatever city you live in, whatever area you live in, what would you do?
Oh, wow, that's a brilliant question. One that I don't think I'll ever be given again outside of this room. Yeah. I think we'd need to be joined up. So to explain that, the way in which we're all commissioned is completely separate to one another. A hospital gets a budget GPs get a budget, the ICBs get a budget. In order for us to make a real shift and change to the system, we'd all need to be joined up. And so taking away those block contracts from hospitals, leaving each ICB to figure out what they're going to do individually, and to a certain extent, which sounds weird because I never thought I'd say this, but to have more of a top-down approach, to be more standardised, to be more centralised, so that there is a way in which there's access at least across the whole of the UK would be the starting point. I think a lot of investment into education and awareness starting at school level has to be the only way in which you're going to shift to prevention. What we find, just to give you an example, is that, we have people in their 25 onward group not coming for smears because they're unaware of what they are or don't feel it's appropriate for us. So there's a falling number of young women that are not coming for cervical screening.
Wow, I didn't know that.
Yeah, and it sits with education. You can imagine why that happens, because they might have got a bit of education in school, and what that looks like, again, it's different in each school. And they then go to work or college or university, and there is no sort of mandate or curriculum on your health. And then you crop up and you get an invite at the age of 25, which may not appeal to you, might not speak your language, etc.
Yeah.
And so this is what we face. And we face that. That's just one example. So I think, if I could take it all under my control, I would invest a lot in education and awareness, because I think, people's health needs to stay with them.
Absolutely. Actually, I didn't even think of the education side of things. I don't think the school system supports that at all. And like you said, there may be some schools that might spend a bit more time and effort going into the detail of that, but it's not standardized. It's not almost like a mandate, right? Every single school across the UK needs to cover these things in this way.
Yeah. There was, and don't quote me on this, she says, doing a live podcast, but there is a curriculum, just I don't know how it's actually implemented when it comes to things like women's health or health in general. The other thing that we find is that people just don't know what normal is, so don't know what a normal cycle is, how your body's functioning. And if you don't know what normal is, then you're not going to know what abnormal is. And I think the other thing is that in order to try and sort of move things forward, you need to be able to then understand that's the foundation. And then the common conditions that you're likely to face during the life course will help you navigate, because your health will change year on, year out. Same with your periods. So unless you've got that foundation of knowledge and then an understanding of what conditions are out there, you're not going to be able to spot it and therefore go along and get help.
Absolutely. And if you're a teenager or a child, you often don't speak up within your household and say something doesn't feel right, or my periods are really hurting me. Or if you don't say those things in your household because you think it's normal or you're not sure, then you're not going to get seen either way.
Absolutely. And I think that's a brilliant point, because there's so much taboo about talking about periods and sex and pain. People for a very long time, particularly women, have been used to being put up with their symptoms and to be quiet about it, and so there's been a lot of reports and research by the Department of Health and the Royal College of Gynecologists about hearing the voices of women and empowering them to come forward and talk. It's not something that they do, and women in particular, whatever age, they've got so much on. There's a lot of multiple roles that they're holding, whether that be a carer for their children or for their family, holding down jobs. So I think there's a lot of difficulty that women face finding time for themselves. And the smear is a great example. It's pushed down at the bottom of your priority because you just think, oh, well, I'll get to it. But it's 20th on your list. Putting time aside to say, no, this is my health, I need to look after myself, and I do need to make sure that I go to these appointments. You can imagine that when you have a problem, people will just try and put up with it for as long as possible because they just don't have the time.
I know you've, transformed things in your community with the community services that you provide as well. But I also know that you have, is it a charitable side of an organisation that you run as well?
Yeah, absolutely. So Pathfinder is the social enterprise, and its mission, its goal is universal care, universal health care. There's a lot of work that we do in terms of supporting other leaders, so thought leadership conferences, trying to get the right people around the table to have exactly these type of discussions about how can we support to scale services, whether it's in women's health or something else. Do some work around workforce training, so how do you support primary care, particularly to upskill, to deliver additional services that we've talked about? And there's work around advocacy. So working with communities, working in schools and education for populations to try and sort of bridge those gaps. So what we've seen is a problem, and we've gone out to try and fix it. You can appreciate that it's not an easy fix because we're talking about multiple systems that need to be aligned. But we've had a lot of support. We've got a lot of support of people wanting to back and understand and also wanting to achieve the same thing. And what struck me is that people aren't shy of wanting to collaborate and make things better. And sometimes you lose hope and think, I don't know, it's a broken system and the money isn't there and nothing's ever going to change. And actually, I come down to London, I meet some great people that are innovating and wanting to do stuff, and they're not just London based, they're up and down the country, really trying to push forward on all of these things. So there's a lot of will, there's a lot of skill as well, and it's just enabling those people, and that's what we try and do through that social enterprise, through Pathfinder.
I think that's amazing. I think you're right. The key, it really is to collaborate, because that is one of the quickest ways you can get things going a lot quicker, basically.
Yeah, absolutely. I mean, without working together, it's 10 times harder.
Yeah.
And we all have different areas of expertise.
Yeah.
Never in a million dreams do I think I would be sitting here doing a podcast. I wouldn't have a clue. But clearly you're an expert at doing this, coaxed me into doing it, make me feel comfortable. I'll come down and do it. But I'd never do it on my own, and there are so many areas now that, when you think about femtech and digital transformation of services, I haven't got a clue, I have no idea what that would look like and don't have a desire to kind of do it, but I would like to work with somebody who's passionate about it. And maybe I could help them with the content or approving some of the way in which it looks. I don't know, maybe help with that. But so that's for me how we can piggyback and support each other.
You're going to get a flood of messages now saying, Aamena, please can you help me?
I do all the time, and it's great. Have innovators come forward. And actually that's a brilliant point, because when I did the service innovation, inadvertently didn't really think it was a service innovation, designed the service just because I had the opportunity and grabbed it. Now I fast forward 10 years and it's not so much service innovation, it's tech and it's digital and people doing home testing and things like that to try and improve care. Similar, they've seen a sort of problem, they've tried to come up with a solution. And it's great to see that innovation, it's great to embrace it. And speaking to somebody like me where I can kind of see it in the system or in a pathway and help guide people is something that I quite enjoy doing, because I don't have any new ideas anymore.
I'm sure you do. You've just designed a new healthcare system. A very quick, 5-minute. So could you talk a bit about the Modality Partnership that you're a part of as well?
So Modality Partnership is a super partnership, about 500,000 general practice population. So we're a large bunch of GPs across the whole of England, from Hull, Bradford down to Lewisham and Surrey and everything in between. So we're primary care at scale. And then the other side of the organisation is outpatient services. So we have 18 outpatient services. Women's health and gynecology is one that I'm particularly sort of fond of, because I founded the service about 10 years ago. But we deliver 150,000 appointments across different specialties, all out in the community, with a bunch of GPs and consultants working alongside each other. So there's an equivalent of me in men's health and cardiology and in dermatology, etc. And then we also have the Pathfinder part of the organisation, which is a social enterprise, which mission is on universal care and improving universal care for all.
So I guess that they're all pretty linked in some way. So it's almost like a huge super organisation that you've got going on alongside the community healthcare system thing that you've set up.
Yeah, absolutely. I mean, I think the thing that I've not appreciated, I guess, over the years, and I appreciate more and more now, is being at scale means that you can open doors.
Yeah.
And with that, we've got a track record. And it's not just now in the UK. Our CEO does a lot of work in other countries, supporting primary care in Vietnam, South Africa, South America, and now in the Middle East as well, in Abu Dhabi. And I think there are similar problems and system strains that are seen globally. And there's a lot of shared learning, both in the UK and from us, to learn from other countries and bring best practice into the UK too. And, you know, we talked about collaboration before. Collaboration is also outside the UK with other countries too.
I think that's great because I think it's a no-brainer. If something's working somewhere else, why not take that and see how you can use it in a different country? Obviously, it's not cut and paste. Nothing ever is.
Absolutely. I had a fantastic opportunity last year. I went out to Saudi to speak with the Ministry of Health about setting up women's health services. And I'll never forget, I spoke about establishing the service 10 years ago and what we'd achieved to date. And they came up to me and said, oh, the problems that you face in Birmingham are exactly the same ones that we're facing in Riyadh. And I thought to myself, that's because health is, the problems that we face are universal. Women's health is universal, as is many of the issues. Sometimes I think we create barriers by saying that there are local variations. But in actual fact, we're all human beings with the same kind of problems, no matter where we are. And the other thing is that there have been huge advancements globally, you know, so places like India, some of the Far East Asian countries have made huge advances both in surgery and tech, in the way in which the services are delivered, that we've got a lot that we could learn as well. Whereas I think we had this feeling that the UK, the US, the West were the leading providers of healthcare and other services. You know, in some ways, I think we need to keep up.
Yeah, exactly. And especially after this BBC report that just came out this morning, I think, we definitely need to keep up.
Behind.
Exactly. We are falling behind compared to a lot of countries, and which is quite shocking, actually.
Yeah, absolutely. And part of that is investment. And part of that is the way in which they have looked to the future and had longer term strategies. So, for example, you know, the countries like Saudi have made pledges for the whole population that are a 10, 20-year plan, and they've put investment around that. I know that other models of care in Australia, for example, have a joint party agreement so that it's longer term with whichever government's in place. So a 10-year plan is a 10-year plan, for example.
Yeah.
And I think that's where we really need to follow.
Yeah, absolutely. Aamena, thank you so much for being on the podcast. It's been fantastic to have you on.
It's been a real pleasure. Thank you so much.